I'm now very excited to kick off the first panel on care coordination. At this time, I'll ask our panelists to go ahead and turn on their videos. Lee and the PCDT team helped us level set with definitions and the activities that are included in care coordination, as well as what we have learned from our environmental scan and from proposals that have been submitted to PTAC. To further inform us about issues related to care coordination, we've invited a variety of esteemed experts from across the country. And they represent several perspectives on care coordination, including providers, researchers, payers, and patient advocates. You can find their full biographies on the ASPE PTAC website, along with other background materials for today's meeting. We have several questions in the queue. We'll work through each one, and I'll vary who's called upon first. In the interest of time, for some questions, I'll begin by inviting 2 or 3 of you on the panel to provide your particular expertise. Then I'll open it up to committee members to ask any follow-up questions they have for the panelists. I'll also ask that each panelist try their best to keep their responses to a few minutes or so for each topic. I'll ask each panelist to please introduce yourself with your name and your organization. Because this is virtual, I will prompt each of you alphabetically by last name, starting with Sarah Berry.
Good morning. Thanks for the opportunity to speak with you all today. My name is Sarah Berry. I'm the Chief Operating Officer of OneCare Vermont, which is a statewide accountable care organization that is all payer in nature and represents about 120 organizations with more than 470 locations in Vermont. We started 2-sided risk programs as an ACO with Medicaid in 2017, and then began a Vermont-specific waiver for a Medicare alternative payment model in 2018. We have about 5,000 physicians and 270,000 beneficiaries in Vermont, and I'm looking forward to speaking with you more about our community care coordination model. Thank you.
Thank you, Sarah. Linda Elam.
Good morning, everyone. And again, a pleasure to be with you. I am currently with Manat Health, where I'm a managing director, but recently I was CEO and plan president of AmeriGroup District of Columbia, which is MCO serving Medicaid beneficiaries here in Washington, D.C. And previously I was a Medicaid director for the district and policy director in Medicaid. So as you may imagine, my primary focus is the Medicaid program and what lessons can be brought from that perspective.
Thank you, Linda. Bill Golden.
Good morning. I'm Bill Golden. I'm a professor at the University of Arkansas for Medical Sciences and medical director for Arkansas Medicaid. We've had an active program in alternative payment models, and we had developed one of the first episodes of care for orthopedics, but in particular we've had a primary care medical home program, which it has attracted 1,000 private practice PCPs in over 200 sites, and we've done a tremendous amount of culture changing and transformation of care that enhances the potential for these sites to coordinate care. And I can make some comments later about the creative use of metrics beyond just measurement and how we tie it in different ways to finances.
Thank you, Bill. Laura Gottlieb.
Good morning. I'm Laura Gottlieb. I'm a professor of family and community medicine at the University of California, San Francisco. I'm delighted to be on the panel this morning. I bring a perspective from the Social Interventions Research and Evaluation Network, or SIREN, which is a research acceleration and translation center that I run here at UCSF, really focused on the advancing evidence on the integration of social and medical care. So things like screening for social needs and supporting practitioners to find efficient and effective ways to incorporate social care-related interventions.
Thank you, Laura. Sachin Jain, please.
Morning, everyone. Sachin Jain. I'm President and CEO of Scan Group and Health Plan, managed care entity that serves over 220,000 Medicare Advantage beneficiaries. Before joining Scan, I was President and CEO of both CareMore and Aspire Health, which were the care delivery divisions of Anthem Inc.
Thank you, Sachin. Robin Newhouse.
Hi, I'm Robin Newhouse, Distinguished Professor and Dean of Indiana University School of Nursing. So I'm from Indiana University. I also hold an appointment as Deputy Chair of our University Clinical Affairs and have an appointment with IU Health. That's our largest health system in Indiana. I bring the perspective first of nursing and second of a scientist that focuses on translation of evidence-based practices and toward improving care and health of people. So I think sounds like I have a different perspective and a different area of expertise than others are bringing. So happy to be here.
Thank you, Robin. Catherine.
Good morning, and thank you so much. My name is Catherine Alexa Metters. I'm the Vice President for Clinical Innovation here at Aledade Inc. My personal background, I spent about a decade in the post-acute care and transitional care space on the operations side, both in nursing homes, hospice, home health, and assisted living, and then made the transition to the value-based care landscape when the bundled payment for care improvement program was launching, and built a company with a great team at Remedy Partners over about 4 years to launch that program in what ended up being about 600 sites across the country. I'm now with Aledade. I've been here for 3 years, originally focused on transitional care and now really focused on clinical innovation to include care coordination across our ecosystem. Our ecosystem today consists of over 8,000 primary care providers across 32 states, representing over 1.1 million lives under management. And really our core aim was mentioned in the previous hour around making the primary care providers practice truly that center of care for patients and families, and enabling them to see both the patients who are coming in today and the patients who they need to reach out to. So that is our aim and the providers we support. And I'm really excited to be able to tell you a little bit about what we're doing during the panel today.
Thank you, Catherine. And last, Sandra Wilkness, please.
Good morning. I'm delighted to be here as well. And I'm Sandra Wilkness. I'm the Director of Complex Care Policy and a Senior Fellow at Families USA, which is a national nonpartisan voice for healthcare consumers. I also bring some experience in policy on the state and federal level. Prior to coming to Families, I worked for 6 years at the National Governors Association Center for Best Practices on health policy issues. And prior to that, 3 years on the Hill. And I'm also a clinical psychologist by training, served as a scientist practitioner for about 15 years, working with people with serious mental illness. Thank you for the invitation.
You bet, Sandra. And thank all the panelists for participating today. Excited to get into the discussion. First off, from your own experience, perspectives, and expertise, please tell us what you see as the role and the objectives of care coordination in the context of value-based care. Also, are specific functions or activities of care coordination most important for improving quality and reducing cost in alternative payment models or physician-focused payment models? And lastly, do these functions vary by context or for specific populations? I'll prompt each of you to answer the question, starting with Dr. Jain.
Yeah, my personal perspective comes from leading provider groups as well as leading a managed care organization that serves older adults with complex needs. I think that the kind of core need associated with care coordination is connecting dots that are otherwise disconnected for people. We have a highly fragmented healthcare system, and the role of care coordination has historically been seen as an integrator or bridging function. I think the most important kind of deficiency in most models of care coordination is a lack of a pre-existing relationship with the patient. My personal view is that we introduce strangers to support patients at times where they need strong relationships rather than strangers to support them. And so my approach both at CareMore as well as at SCAN has been in trying to proactively identify patients who may need care coordination in advance of them actually having an acute need, try to build a strong relationship with those patients in anticipation of future needs, such that that relationship capital is available for patients and families at a time when it is going to be valuable for them. I think in the absence of that, you see, care coordination can oftentimes, almost appear like an intrusion in the physician-patient relationship, as opposed to an important adjunct. And so, my personal view is that we need to kind of emphasize the existence of care coordination relationships and anticipation of them being needed, as opposed to injecting them at an acute moment in a patient's life.
Thank you. Robin?
Yeah, the importance of care coordination is to understand the needs and the goals of people, their health goals, their family, or the community, and to improve outcomes that are important and they care about in a patient-centered way. Better health, lower cost, lower utilization. So care coordination is about optimizing health in ways that people can make positive changes and become resilient, healthier, and live the life and achieve the goals that they intend to achieve. And thereby, it avoids a misallocation of resources. So there's not those failures in some of our processes of care. But the whole point is to improve health and help people live the life that they intend to live.
Thank you. Linda?
Well, I'd like to echo the previous comments. And again, coming from a Medicaid perspective and where we've had a long history of managed care, capitated payments and value added benefits and sharing risk as appropriate with providers, it's clear that you have to start with the person and what it is they desire. Different populations, different individuals, different contexts require different approaches, but a whole person lens is a constant that should be involved. I'd also add that determining appropriate reimbursement is key, but that payment itself is not enough to drive these important connections. They have to be intentionally developed and maintained. Care is clinical, but a huge part is non-clinical for the populations that I've worked with. And so connecting people not only to follow-up appointments or making transitions between care, but also assuring that they have access to support such as housing, food, and other elements that help them achieve optimal health is really important. I think the last thing I'll say is that, IT is another thing that's hugely important, but is not sufficient to really drive success. You have to have that personal touch, as was discussed earlier.
Thank you, Linda. Catherine.
Yes, so on this part, I think from my personal experience, it's been interesting to work across different parts of the ecosystem. And I really think it's important to bring out a point here around a very different view of who the care coordinators should be for which patients at any given time. And I think Sachin brings up an amazing point around it has to be a relationship, right? But what relationships and with whom and for how long and for which patients is always the question. And the last question, which this committee is considering, is how do you pay for it? How do you get the right money to the right folks at the right time to actually perform these functions? And you may get a slightly skewed view from me as someone who's now really committed to this concept that the primary care practice is that entity. and is that unit that needs to behave as the care coordinator and the quarterback for these patients. And when we think about the for whom, they certainly shouldn't be performing the care navigation functions that were mentioned for everyone. I was using an example yesterday about my recent pregnancy. I had my first child last year, and my insurance plan offered me a care navigator for my pregnancy, which was great, but I didn't need it. I was someone who could manage all my appointments. I was someone who could really get it, and I knew what I had a great relationship with my physician, and all of those things were taken care of, and yet I was offered this care navigation service. So I think it's really important for us to understand who should own this care coordination relationship, which patients at which times in their lives need help and need support on this, and really come at it in a unified way. So it was also mentioned previously that you know, we could have the possibility of getting to maybe what I would think of as an idyllic future state where all of the folks in this ecosystem that we live in are communicating via, I don't know, Tiger text or something, and we're all just like totally on the same page. And I'm not sure that that's something that's within our reach, certainly not in the current state. And we certainly saw how that wasn't happening through the pandemic, right? And I think everyone is well-intentioned, but having an anchor of where we can focus this care coordination work, which is the primary care practice, has to be something that I think has to underline our common framework around how care coordination should work. And I think really when you think about that, there's two components, right? What can the primary care practice accomplish on their own? And how do we make sure they're resourced to accomplish that? And what do they need to bring into there to support patients, you know, similar to some of the work that Sachin had done in the past related to CareMore or Aspire, the more deep, complex care management that the standard primary care practice isn't positioned to deliver. So those would be my 3 points. Thinking about the primary care practice as the quarterback and how do we set them up to be successful and not come at the patient from the payer in the hospital and all different types of care coordinators at different points in their life with no quarterback. And then how do we make sure that the primary care practice can pay for that? And how do we make sure that they are able to bring in other services as needed and as appropriate? And frankly, from a financial model perspective, are incentivized to do so.
Thank you, Catherine. Bill?
Yeah, thank you. I'm going to step back to about 50,000 feet and talk about the need to really redefine what healthcare is all about. Back in 2012, when we launched the first episodes of Care for Total Hips, what we began to tell the provider community is that we're not paying for an event, i.e. a surgery. We want to pay for a patient journey. And by creating the episode of care, that itself drove care coordination, because suddenly the orthopedic surgeon was interested in what does post-surgery rehab look like? Where does it happen? What is the pre-surgical education of the patient to prepare them for the rehab? So by switching to the patient journey rather than the surgery as the core function of the payment, people began to rethink what their product was. Likewise, primary care, they are many times stuck with the visit orientation because of their overhang. And so we tell people when we launched the medical home program in 2014 that they are not being paid for visits, they're being paid to manage a panel. And when I chaired the LAN's panel on primary care payment, there was universal agreement that we need to change payments to tell people that they are managing panels and not visits. And when you do that, that begins to change culture and beginning people to think, what do we do? What kind of services do we need to manage a panel? And I can tell you later on, I'll talk about metrics that you need, because you first have to identify what's important.
Thank you, Bill. Sandra?
Hi, yeah, it's always a challenge to clean up here and to say something new and different. But what I would like to underscore, I think that has already been touched on, is really that the purpose of care coordination, when done well, is to meet the needs of the person as holistically as possible, and prioritizes that person's goals. I mean, I love the quarterback analogy, and I see the value of those kinds of models. And what I would add to that is that the person served should be part of the coaching team, right? We're really in a space where we can move to a shared decision-making kind of approach when we think about how to inform not only what services are offered, but the care coordination aspects of those. The care coordination approach should be laser focused on that holistic set of needs for that individual, including his or her own stated goals. It allows us an opportunity, when done well, to really centralize care coordination, to step back and remind ourselves that the majority of health outcomes are not clinically based, right? They're determinants of health, and we can get into the details of what those are, and I'm sure we will later. But a small sliver of what determines health is in the clinical setting. So stepping back and reminding ourselves of that really can inform a high quality care coordination approach. And I would say that that means the value proposition in health hinges on doing that successfully across healthcare, behavioral health, determinants of health settings, including food security, housing. We've talked about this already, environmental factors, but also things like wealth and social capital are really key determinants of health outcomes for people and should be thought of in the care coordination approach. And I know we'll get into metrics later. Bill just mentioned that, but I would say that if the goal is improving someone's quality of life, working back from that then determines what the care coordination looks like. And it really makes a strong case to move away from fee-for-service to alternative payment models that allow that flexibility, allow that type of coordination across different provider types and that communication. And that's what patients want, and that's what providers want to get back to. That's why they got into business. So those were, just some reflections based on what others have said.
Thank you, Sandra. Laura?
Yes, it's either really hard to back clean up or it's a lot easier. I'm not sure. I don't know whether it's better or worse. But I certainly, don't think that we need to rehash what the role of care coordination is, or why it's important. What I think I'll do is just layer on the social determinants frame, which I think a lot of people have already alluded to. But we did some work with the National Academy of Medicine that I think kind of helps to frame a lot of the interventions that people have pointed to. And I think it offers kind of a useful organizing framework for really categorizing the different types of care coordination activities that are critical. So one of those is the National Academy referred to as awareness. Like you just can't coordinate if you don't know what you're coordinating or what the patient's real needs are. And so that, this need for social risk screening and some consensus around what are we screening for is really critical. And then second, the committee moved into a whole slew of interventions. I shouldn't say a slew, 4 categories of interventions, both very patient directed and clinical care directed, and then some very community directed, which others have kind of highlighted that you also need interventions that are kind of changing community level circumstances. But the patient directed ones, this kind of the capacity of whatever clinical setting, whether it's primary care, as Catherine's highlighting, or an emergency room setting, to bridge health, medical, and social services has really been lacking. We've lacked shared data. We've lacked shared data governance. We don't have the technology systems in place. We don't have the ethical guardrails for how we share data, et cetera. There's a lot of work that we need to do that's focused on assistance, on just doing that bridging between medical and social care. And then the third category that I think is really relevant here is that we can use social risk data that we collect to really change the care that we are providing that is really medical care. It's not just like, bridging to external services, but to improve the care that we are providing. More cost thoughtful or cost conscious prescribing, providing telemedicine services, but making sure people have digital or broadband access. Like, there are just so many things that we could be doing more thoughtfully if on the actual within the medical care wheelhouse. But all of those require workforce and workforce training that is very relationship-centered, technology, cross-sector data sharing and governance, and then I think ethical guardrails that we have yet to develop. I'll leave it at that for now.
Thank you. Sarah?
Thank you. That was a perfect segue, because the way I think about care coordination is really from a systems perspective as a cross-community organization, kind of aggregator as an accountable care organization. So in Vermont, the way that we've really deployed our program is thinking through the lens of population health management. And more specifically, our complex care coordination program has really come together as an organizing framework for us to reduce fragmentation and to focus on increasing person-centered and team-based care. It's really critical, and I can't believe how often I have to say this, but as an ACO, we don't actually deliver care. We provide care models, we provide data and analytics, we help reform payment structures to move deeper and deeper into value-based care. And of course, that comes with some tools and resources. But it's really all about the healthcare providers in our network who have those established relationships, as previous panelists have mentioned, and the work that we can do at the systems level to help make the providers' lives easier, to help optimize that care process and those outcomes. So in our care coordination program, we've really worked to align expectations across different provider organization types. And that began by just defining what is a common vision for person-centered care. And that took many, many months longer than one might imagine. And we learned from that across healthcare organizations and across disciplines, people did not use the same vocabulary. So we had to back up and have conversations. What do you mean when you say this or that? And in doing so, we were able to create that foundation, agree on and unify some tools, and ultimately arrive at a singular tool, a shared care plan tool that everyone agreed to use, that is very person-centered and really facilitates a dialogue and conversation with an individual about what their goals for their care are. In that process, learned that oftentimes, as other panelists have mentioned, those goals are more about how I live my life every day than necessarily the clinical care. It's, I want to go to my grandchild's graduation. I want to walk to the end of the driveway to get my mail, whatever those things may be. And I think in recognizing those stories and anecdotes, it allowed our care team that is founded in primary care, but more holistic in the sense that it integrates with home health and mental health care providers, congregate housing, and others, to really identify themselves and their own expertise and how they can add value as part of a broader care team. So we've really structured our incentive programs in value-based care to ensure that broader community care team has resources and tools available. Continue to work on the education and resources to help support and continually learn from that process. I did just want to reflect briefly on the patient-centered medical home perspective and say that, as an ACO, we foundationally believe that primary care is the center upon which we create health and wellness, as well as manage populations most effectively. And so we are always trying to balance investments in short-term interventions, things that are condition or utilization specific, with really making sure that we have a portfolio of upstream investments in prevention and wellness. And that's hard because that doesn't, materialize in dollars saved at the end of the year necessarily, but we really think it's critical to foundationally changing the way healthcare is delivered. So with that, I would just say that the final advantage I see coming from a collaborative ACO model is that we do have the ability to integrate insights from clinical care, utilization, claims data, social determinants of health data to really get a holistic picture of population health, and then to work with our providers to drill that down to an individual's needs and how they can best be met. Thank you.
Great. Thank you, Sarah. So that was our first section. There are a total of 4. The next one, as you know, is COVID-19 brought unique challenges. Coordinating patients' care with immediate disruption of regular delivery of services and quick expansion of telehealth. Can you speak to the evolution of care coordination, especially as it relates to any lessons learned over the last year and a half? And are there any specific lessons connected to equity We'll go ahead and start with you, Sarah, then we'll go to Laura and then Sachin. Thank you.
Thank you. So I'm going to pick up right where I left off and thinking about OneCare as an ACO and a central convener and organizer of healthcare providers and working collaboratively with human services. I really think that we have been able to take advantage of health information technology. And an example of that is in April last year, as we all started to have a better understanding of public health emergency, we were able to use some algorithms that we developed based on really best practice nationally to identify vulnerable population panels. And by mid-April, we had that out to over 800 care coordinators statewide so that they could reach out. And we asked first that they conduct care and safety phone calls, just check in, right, and see how people are doing. Certainly people that they were already engaged with, but we also talked within primary care practices about how people managers could do some of that outreach as well. And we learned, I think, immediately 3 key things. First, social isolation was way worse than any of us could have guessed. And in a rural state, to hear how quickly it ramped up to become a significant problem was somewhat astonishing to us. Second, and very practically, pharmacy refills were a challenge. And that was something that people could operationalize around pretty quickly. And then beyond that, we were really starting to think about how to use telehealth services and to have conversations across not only with our public payers, but with private payers as well about how we could create flexibility. And then, pretty quickly after we got some of the flexibility for audio only calls and for some of the telehealth, we actually realized as a rural state, we have foundational problems with broadband access, right? We have people that are in communities that currently have no internet access and probably won't for quite a while. And so in that situation, because we have a community care team model, those community teams were still coming together virtually in a format that they already had established, and they were reallocating kind of roles. So if you're going to be on the road, can you check in on this person for me? What can we do to think creatively? And in our congregate housing sites, as an example, they recognized that they could really accelerate the uptake of telehealth by buying some tablets and creating a lending library for their housed individuals. And they also realized they needed to provide training and retraining and some support along the way. But that's turned into a very successful program that we've talked about how to really sustain that in the long term.
Thank you.
If I could just finish one thought on the provider side that I think will affect many of us for years to come, and that is that beyond the rural nature of our state, we have workforce challenges that are growing exponentially. We have an aging population. We have people that are burned out and really don't have an idea about how to recover from that. And from the ACO's perspective, what we've been trying to do in that space is really try to focus on workforce satisfaction and where they feel they can connect with individuals and get some of the kind of energy and rejuvenation back, as well as providing skills development training. So finally, with health equity and disparities, I think I just need to put a plug in that we need more centralized data. We need to better understand how the data that we have available to us through health information exchange, through claims and clinical information can really truly be aggregated and be used to identify a whole host of vulnerabilities that then we can convene policymakers around. And these will be things like housing, investments in broadband and in transportation, all big issues that would increase the satisfaction of our citizens as well as our healthcare providers. Thank you.
Thank you, Sarah. Laura?
Yeah, so the question is about what we saw change in the COVID-19 context that we could apply towards the future, and then what are sort of some big equity considerations, or as I heard the question. And I would take Sarah's amazing examples of what they're doing in her region, and I would generalize because this happened in a lot of places. So we saw an enormous wave of innovation in response to this crazy tragedy that we are still in the midst of going through, where health systems and many social service systems, I mean, just this huge cross-sectoral alignment, really changed business as usual. They overcame reluctance to do different tasks, to wear different hats, and to work together to get it done. And that's obviously a very positive frame, but I'm going to run with it for the moment, and then we can talk about all the downsides or the negative frame too. We saw suddenly that healthcare systems who had been very resistant to screening for housing instability or homelessness, suddenly were screening every patient who walked in the door. What? Not only did we see a change in the prevalence of screening, but we also saw a change in what they were screening for. So people started screening, as Sarah mentioned, for social isolation and for digital or broadband access, internet access. And then we saw changes in using that same NAM framework, the NASM framework that I mentioned. So that's kind of the awareness. What were they screening for? We saw changes in what they were willing to assist with. So we saw healthcare providers that were expanding home delivered meals or providing temporary housing and doing remarkable alignment to get that done. And then on the adjustment side, we saw this tectonic shift to telemedicine that was really, if you think about it as an adjustment, we adjusted care based on the social needs of our population. And of course, those all intersect, right? So you can't provide telemedicine without also providing more, maybe bigger loaner programs. So we saw these smartphone loaner programs, as Sarah's alluding to. We saw other ways where people were paying maybe for 6 months of broadband access to patients or doing other remote monitoring. So we saw these huge shifts. And now I think it's incumbent on us to think about, well, are we going to strengthen, sustain, and scale those changes? Is that possible? And how is it possible, and for whom? And that's where I think some of the big equity questions come to play. So and I mentioned this in my prior comments, but what are our ethical guardrails around this? How are we sharing data? Do patients have the ability to consent to sharing, to whether or not their data is shared? Can they change their data if we're pulling data from big consumer, data warehouses? Can they say, no, that's not right? What does it mean if we're, asking patients to go who are experiencing housing instability to go to housing facilities if that's pulling them away from their families or maybe making them more socially isolated? I think there's some big questions also about just the availability of these new services or this sort of change in services or strengthening services across the healthcare sector. Our settings that are, as a Kaiser member, it was awesome when somebody walks me through how to connect to my provider in a virtual visit. But as a safety net provider at San Francisco General Hospital, where we do not have a single person who is going to help my patients figure out how to use the technology, we haven't done a single video visit. So that kind of ethical dilemma that we're facing in providing these new sort of socially informed care models is really a problem. And I don't think that we as a community of healthcare stakeholders who really want to improve patient care for everybody and address health equity have really adequately grappled with those questions.
Thank you, Laura. Sachin?
Thanks. Yeah, I would say there were two kind of key areas of focus, one of which was already touched upon, which is, loneliness and social isolation. One of the things that we were able to do successfully was actually leverage a group of our members who we had already, kind of had on staff as, member advocates to help people navigate their benefits. We were able to leverage them to actually provide outreach to people we believe were at high risk for social isolation and loneliness. And the kind of impressive kind of benefits we saw from that outreach form the basis for our new Togetherness program, which is really focused on peer-to-peer outreach kind of leveraging, seniors to actually help seniors. So that's been, kind of a key learning coming out of the pandemic. And again, I think having a peer help you navigate the healthcare system was, I think, in many ways seen as superior because there was a higher degree of empathy, expressed, by individuals who are experiencing very similar challenges. And I think that was an important learning for us. I think the second was, in advance of the pandemic, we had introduced a new benefit called our health tech benefit, which was really, in shorthand, the Geek Squad for individuals who are using technology to access healthcare, and that turned out to be a very important benefit for our members as they, increasingly leveraged technology to access healthcare. We saw, utilization, kind of far exceeding our expectation, and really recognize the individual needs that people have to get that added level of support around how they could use technology to access care. Brief anecdote, we expect that people, have all the things in place to do these things, but, many of our, one of our members didn't even know how to set up an email account. And so, which is oftentimes a precursor to actually using a health tech benefit and using a telemedicine benefit. And so we were able to use our health tech benefit for that member to actually get them the support that they needed, to handhold them to actually set up the email account. And so, again, I think when we think, holistically about care coordination in this new world, where telemedicine is going to be an increasingly important mode of delivery, we have to think about putting the supports in place that are going to actually enable people to get the kind of care that we think they can access, readily. But in fact, oftentimes there are unexpected barriers to actually accessing care. So something that we're, I think some learnings that we're going to definitely carry forward into the post-COVID-19 era.
Are you on mute, Jeff?
Of course, I'm on mute. I was saying I'd like to open up this section to the other panelists that may have a point of view on this particular topic. If you want to raise your hand, we'll try and identify you. It looks like Sandra's got her hand up.
Yeah, great. And I'll be brief. Thank you. I just wanted to add that along with the social isolation, which is so devastating, of course, we've also seen major uptick in anxiety, depression, substance misuse, especially among young people. It's really an opportunity and a necessity that we intervene there. And I think as we think about care coordination, that's got to be a major focus. Telehealth has played a vital role in creating access to that and audio only opportunities in places with less access to broadband. And it's popped up in really important places. Like I've learned that crisis response providers have found that telehealth options are really valuable in staying connected with people who need those services. And I think that's a real opportunity across system to really make some connection there to serve those folks. Just two other quick points in terms of the workforce and the workforce burnout, which is also just devastating. There are workforce extenders, if you will. It's not the best way to say it, but people who provide peer support services, community health workers, caregivers who are really filling those gaps and can be important contributors to really coordinated care. And the last thing I'll say about equity is, for us, the testing and vaccine distribution approaches and data around that have really brought into full relief the ongoing disparities, especially around in communities of color. I mean, it's just a tragedy how different access is in those communities. And it's not just based on hesitancy, which is sometimes in the media. And I think along with data and effectively gathering data by race and ethnicity and disaggregating those data, we can't wait. We know roughly where some of these needs are, and I think just need to jump in right now.
Thanks, Sandra. We have Linda and then Catherine.
Thanks. And I just want to underscore that, obviously telemedicine has been hugely important during the pandemic, but we've also seen how there are disparities in provider ability to engage in telehealth activities as well. So beyond just what that means for providers in the system, it also has a downstream effect on the populations that they historically serve as well. So I just wanted to make sure that that element of the telehealth conversation was lifted up because it does have the potential to further exacerbate disparities in the system.
Thank you, Linda. Catherine?
Linda, thank you for saying that, because I think it kind of segues nicely into the point that I'd like to underscore, which is that I think even at Aledade, as a convener of primary care physicians in MSSP, shared savings programs, and ACOs across the country, I think we had not fully realized the fragility at times of the financial situation of some of these practices. And when patients stopped walking in the door last March and everyone had to stay home, there were really two major problems. One, there was no money coming in to the practice. And two, they didn't even know who needed help out in the community and which of their patients they needed to reach out to. And this was an incredible opportunity for us at Aledade, because we do serve, as Sarah was mentioning, as sort of the infrastructure for them to, in this case, actually get access to a telehealth platform. We ran a sprint to stand up over 400 clinics in a 2-week time box on a telehealth platform that we procured for them, because maybe only about 1% of our practices even had access to a telehealth platform prior to that. But we also used the analytics power that we have as the ACO sort of enabler to surface the patients that we knew from the literature that was still emerging at the time, which patients were most at risk, frankly, for mortality. And we said, we know you're struggling on staffing. You've got people who aren't coming into work. What can people do from home? Well, they can call this list of patients, and we gave them a protocol to help understand. And to the earlier points that we made around social screening, that's really what it was. Do you have food? Do you understand the risks? Do you understand how to stay home? And we called it the Stay Well at Home initiative. And so I think that the critical point for us, and I hope for this group as well, as we consider funding for care coordination programs and alternative payment models, is really to say, what have we learned about what's absolutely necessary to do this work in an emergency? Because those same things that are necessary in the emergency are necessary every day for these practices. And I think focusing on the ability of primary care to not be dependent on that fee-for-service patient walking in my door today and having a 15-minute encounter is absolutely critical to our success in care coordination and, frankly, in alternative payment models in general. So it's been hugely eye-opening for us as, you know, sort of thinking about shoring up the base of the financial stability of primary care, as well as making sure they have the data and tools they need to do their job.
Okay. Thank you, Catherine. I know Bill has a comment as well.
Just to follow up on the last comment, Medicaid is not a big payer, if you will, in terms of dollars, but we've had many practices, pediatrics and so forth, tell us how important our alternative payment PMPMs have been to keep their doors open during COVID, because the dependent, as I said earlier, the overhead overhang can be very, very damaging to these practices, and shifting to more upfront dollars with less reliance on visit fees from bricks and mortar visits was critical, and we'd like to see more shift to that in the future.
Thank you. I'd like to just reach out to the PTAC committee members if they had any questions for the panelists at this point, and before we move into the third of 4 sections. I have one, but I'll look to see if others want to go first. All right, not seeing any hands fluttering. So we've talked about burnout a couple of times so far. The panelists have raised it, and there's a study that shows that pre-COVID, about half of the providers, physicians, and clinicians were either significantly disappointed or burned out. Post-COVID, now that number has gone up to about 60% are either financially, physically, or emotionally depleted. And one of the things that is driving them underwater, if you will, is obviously the burden of practice and the administrative requirements. And care coordination, as we've talking about, is so vital to driving high quality outcomes. But on the other hand, you can imagine if it's forced, if you don't have the infrastructure, if you don't have the template and how to do it, it can be seen as yet another burden. And so what I would ask, I know Catherine, with Allidaid, you're sort of at the elbow with the practices, helping enable them with care coordination and what they need to focus on in the moment. But I really would like to open it up to you, Catherine, and others to talk about what have you seen as best practices that really make care coordination part of the fabric of care delivery without it becoming overly burdensome to the provider community. Thank you.
I'm so glad we're going to talk about this because it's certainly on the forefront of our practices' minds, and some of that has resulted from just the busyness and the emergency response mode that folks have been in for 15 months, as well as the financial burdens that have been on folks and wondering if they're going to be able to pay their staff, et cetera. In terms of implementation of care coordination activities, I couldn't agree more that it can feel onerous and cumbersome. And how do we get there? What's the roadmap? And the first question is always, who's going to pay for my staff, hiring staff, right? Because I think, we work with practices across the spectrum, all the way from the small solo practitioner in Arkansas to the large, multi-site community health center in New York City. And I think the answer on implementation and making care coordination the grease on the wheels instead of the friction, kind of to your point, Jeff, is, we have to have the resources in place, which means there has to be funding for those resources. But I think it's also important to remember that if we put a lot of requirements and enablement, what we think of as like enablement criteria around the payment model, it does become onerous. So the way we have seen it work, and if you read Brad Smith's recent review of the CMMI programs over the last decade, he talked about, comprehensive primary care plus. And unfortunately, that program, which paid for care coordinators in primary care space, effectively upfront money, and had sort of these enablement requirements of you have to check these boxes to get your check. That alone did not work. It ended up costing the system more than it saved. And the one bright spot there was that the practices who were participating in CPC Plus and MSSP, so really more of the financial alignment model versus the enablement model, they actually did succeed at a much higher level. So allowing the practice to participate in a model that financially aligns them to the goal, the outcome, and not only on the process, we think is so key. Because when you look at this, this spectrum of practices, reducing burnout is going to look different in each segment. And ensuring that they have the right tools and staff and process is going to look different. So really thinking through that, how do we make care coordination the thing that takes something off of a physician's plate, a provider's plate? How do we make it hum in terms of the support system and the support structure for the physician, I think is really a key to success in reducing burnout.
Thank you, Catherine. Laura, and then Bill had a comment to my question.
Yeah, Catherine highlighted some of the points I wanted to make, so I'll do a slightly different tack, which is just to really underscore how important the social determinants component to this is. So we did a study across, I think, 500 different healthcare providers in the San Francisco Bay Area, and we saw this tremendous correlation between the capacity of the organization to identify and address social adversity and provider burnout. And then the American Academy of Family Physicians replicated that survey in a recertification process that they had and found the exact same thing. So the ability of the practice to identify and intervene on social adversity is highly correlated with provider burnout. I can't emphasize that enough, because we think about all the other dimensions of burnout, the EHR and the payment problems and the keeping your staff and retaining your staff, and there's so many pieces, but we have to add to that mix the capacity to really provide whole person care, which providers recognize is really critical. Clinicians recognize is so critical to effective, high quality care. And then the second piece that I think is really important here is the workforce point that Catherine made, and I'll just briefly say that I think while we recognize that the social adversity related interventions are really important at the organizational level, it can't fall to the advanced practice clinicians to do that work. And again, we see people who are more satisfied with their social care programs who have community health workers, other patient navigators, or the availability of staff who really are able to develop relationships, know the community resources better. And it's not so much the technology that makes the big difference there. It's the staff and staff training that really makes a big difference.
Thank you, Laura. Bill?
Yeah. Arkansas Medicaid is not managed care, but we have invested a lot of money in providing data feeds to our practices to help them understand what they're managing, as well as working with our health information exchange and also provider networks, phone calls, so people can model with each other. But Catherine mentioned the CMMI article that was appeared about the costs. And I think there's a flaw in that article and that thinking, because fundamentally, as we get into medical homes and the investments, it's a different product. You're not paying for visits anymore. You're paying for a panel management, which is a different cultural product. It's going to cost more. And when you say you're paying more for that product, it's really a product that's more consistent with the new National Academy of Sciences report of what primary care could and should be and how you pay for it.
Thank you, Bill. We've got 30 minutes left. We're going to move into the next section, which is really getting your thoughts on opportunities, best practices, and facilitators that you see for implementing and evaluating care coordination activities broadly, including any specific care delivery models, payment mechanisms, and performance measures that have proven to be most effective. I'll go ahead and ask Bill to start, and then we'll hear from Robin and then Catherine. Thank you.
Thank you. So we have been, on this journey for a while, and we have used metrics different ways. One is, what is the structural aspects of the practice environment? A second one are quality metrics that we use as a toll booth you have to pass in order to qualify for bonuses, and then bonus money. So, you can use metrics in different ways. And when we started with PMPMs to rural primary care practices, we said, first of all, no more answering machines at night. You have to have 24/7 live voice access. If you can't reach your doctor, you can't coordinate care. And within a year, we got rid of answering machines in the state of Arkansas, which may not sound like a big deal, but that's a pretty big deal. We also began to demand that their notes look a certain way, that they identify high priority beneficiaries. Do they have a problem list? Do they address the problem list? The quality of the patient care notes was frankly awful. And I suggest if you go out to a lot of primary care practices in the country, they'll be similar. One of the biggest failures that these notes had, there was no statement about when the patient had to come back. Well, how do you manage diabetes? How do you manage asthma if there's no return visit set up? You can't do it. So we began to change the expectations. And that was a long journey. It took 3 years to get people to realize that their fundamental notes that they had to do and the metrics we put in place were critical in order to coordinate care, because you can't coordinate care that you don't know needs coordinating, or you don't, when you see the notes, what's the patient's expectations and needs. So those are the kinds of things we've been doing. And frankly, that when we start putting those expectations into the structural aspects of what we built, it starts changing how people get assigned duties in the office. It starts to empower the nurses differently from the physicians. And we had a practice in South Arkansas, at El Dorado, Arkansas, that became the poster child for CMS about what can happen in rural sites, because they redesigned their practice with color-coded care teams, with nurse practitioners and physicians and care coordinators teamed together with different color scrubs, and totally transformed the product they delivered in their. So, and it also resulted in them being able to recruit people to work in their practice, as opposed to desperately trying to find people to come to their town. So I'll stop.
Thanks, Bill.
I'll talk more about the implementation part of this question. And I think this is just such an important area, because we have many models that we know work, that are efficient and effective. The American Academy of Nursing, for example, has close to 20 care coordination models that have already demonstrate both cost effectiveness and efficacy for implementation. Now, we're talking about this as if care coordination was one thing or one intervention, and I'll come back to that before I finish. But how do we get these models into practice would be what I'd like to address. And I think the first step is, number one, making sure we think about this in terms of a diffusion of innovation. So there are lots of models that help health systems implement evidence-based practices, and just like care coordination, where we start with the antecedents, we get the organization ready, we work on implementation strategies, etc. And we have both clinical, administrative, patient outcomes that are associated. Certainly their interaction with broader kinds of things like the resources available, change agency, etc. But also there's something about the active strategies that we use for implementation. So I think thinking systematically about how to get these and spread into practice would be fantastic. You probably are familiar with Mary Naylor's transitional care model, and there are many more like that that could be spread very easily. We in Indiana, we had a very innovative physician, Krista Brocker, who started a Project Point when patients came to the emergency room that encountered that had an overdose from narcotics or opioids, were then paired with a peer recovery coach to transition them into the community. That was incredibly effective with getting people into treatment. So I could go on and on about the number of models that we could spread, but the implementation strategies are sort of one of these things that are in a black box for clinicians, that we have to make it easier for them to use and not more difficult for them to use. So creating a structured approach is important, as well as providing toolkits. So those that are developing these interventions have to help clinicians know, how can I use them, and what are the essential parts of this intervention, and what are the points that I can adapt or change, because contextually I have some difference in my practice setting. So creating toolkits would be, I think, another strategy. In addition to introducing the implementation strategies, for example, the expert recommendations for implementing change, ERIC strategies. So when we do a study with health systems, we provide this toolkit with these strategies and help people understand how to use or tailor the way we implement to their own practice and their own context, which, by the way, context does affect our effectiveness of care coordination. So I think certainly in describing what the components of the care coordination are another very important part of this, because as a complex intervention, there are many moving parts, and sometimes these parts are independent and sometimes they're interdependent. So understanding what parts of this care coordination are important are something that we need to do as investigators that would develop these care coordination models, but it has to be clear what that causal link is from that function to the outcome. So we have to spend some time thinking about that. And when we implement the care coordination models, there should be an evaluation plan that corresponds as well to describe this process evaluation so that we can learn from each other. And oh, by the way, the outcomes that we select should also be included. The other thing about implementation, I think the functions of care coordination that we talked about in the model, the HRQ model, these are things that we do as clinicians. And this whole issue around the methods of patient engagement and how we engage people in setting their personal goals and the family is incredibly important. There's the work that Bakori did, the Patient-Centered Outcomes Research Institute did early about what is patient engagement and how do we engage patients, and that's in terms of comparative effectiveness research, not implementing into practice. But I say this because there's a way one engages, and there are many, many different strategies. We have to learn to engage well, understand those personal preferences, values, beliefs, and goals, because they are central to our ability to achieve the goals that people want to achieve. And then, their goals are usually tied to our goals. We might talk about them in a different way, but I think that's absolutely foundational to the ability for us to translate these models.
Thank you, Robin. Catherine, please.
Thank you. I really appreciated Robin's comments on implementation. And I think the comments I'd like to make are really going to be focused on how have we organized primary care practices holistically to achieve success in the shared savings programs that they are a part of. And when I think about care coordination, I think one of the challenges we have with the payment model for folks who are not in shared savings programs is that it really does silo the care coordination or the care management activities. And we have maybe an overly casual phrase that I'll share with you all here. You don't want a care manager in a corner, working alone, calling patients for 20 minutes a month, trying to bill CCM codes or RPM codes or whatever he or she thinks are the right interventions to perform for the patients. And you don't want provider A saying, I'm going to send you over to Sandra's desk and she's going to really work with you here, without having some of those really actually integrated approaches for the care team. And so when I think about how we incentivize our practices, and I would never come to this panel and tell you we've figured out the recipe card for care coordination, because we are just frankly, after 7 years, I would call us sort of at the beginning of our journey on this. And last year was an incredible eye-opening thing around care coordination with telehealth appointments and doing many of the things others talked about there. But really, if you can align the physician around the outcome metric that you're trying to achieve, right? So there's the idea of implementation of required elements, like Bill was talking about. There's the implementation of a specific care coordination model that Robin was talking about. But I think the truth is, if we peel back the layers and we really think about the people in these practices across this country, they are tired, they are overwhelmed, they are booked from morning to night. They've tried 10 different things, they've tried 10 different technologies, and they just can't see their way through it. And so putting a whole bunch of new requirements on them or quality measures on them is not going to get us what we're hoping for here. And so if we can start to align around, as we are currently doing in our ACO programs, like how do we have the funds flow to the practice based on the outcomes that they're able to achieve? And then they're going to be looking for the recipe card. So instead of saying, here's the recipe card, implement this, we're saying, here's the outcome that has the dollars attached to it, whether it's, a percent of transitional care management visits and 30-day episodes that have been initiated and completed for patients who've come out of a hospital, or if it's, the number of formerly severe hypertensive patients who are now controlled, right, because they've had their appropriate follow-up protocols. The practices then come to us and say, well, tell us how to get there. Give us the ADT data that we need to know when patients are coming out of the hospital. Give us the protocol so that we can implement it across our care team to make sure that those patients who have that 160/100 blood pressure actually do come back in the next 2 weeks. And we don't just say we have a protocol, right? We're actually working together because we're all aligned. So I think really focusing folks on the one thing that is existential, which is their finances, their funding. For the community health centers, it's a slightly different perspective than the private practice, but they still are reliant on their grant money, their funding, and then saying, how do we work backwards from that to actually implement programs that work across the care team and not have the care manager in the corner making 20-minute a month phone calls? We're not going to make progress until we can get there. So I'll report back, but that is the journey we are currently on.
Thank you, Catherine. And I want to open it up to other panelists. And I know Sachin has a comment he'd like to make.
I want to just plus one and bold and underline Catherine's sentiment around, kind of having, sometimes the wrong people reaching out to patients. One of my observations with this work is we oftentimes have kind of the least experienced people in the healthcare system kind of levered to actually work with the most complex and difficult to manage patients. And we have this, workforce problem where I think we're constantly trying to lower costs by lowering the skill level of the individual performing tasks. And in fact, the population that needs care coordination actually requires a combination of medical, social, psychological kind of management, oftentimes which is outside of the scope of the people who are actually performing the frontline work. And so you do have, oftentimes largely unsupervised, kind of lower level healthcare workforce interacting with kind of some of the most complicated and complex patients who are oftentimes looking for answers that the person on the other end of the phone or the other end of the interaction are unable to deliver. And so this question around who is the right kind of care coordination workforce is really important. I know Catherine's perspective is that it needs to be, kind of driven out of the primary care physician. I couldn't agree more. At the same time, I think there's a notion around supervision models for people who are doing this work because, in practice, they are largely unsupervised, doing the very best they can, as opposed to operating within a framework that produces robust outcomes. And so that's why I think the data on care coordination has always been as mixed as it has been. I don't think it's a bad concept, but I think, ultimately the workforce that we put in place to do it is often underpowered to do the work that we actually ask them to do. And I think it creates more cycles, not less.
Thank you, Sachin. Laura?
Sorry, it was a little hard to get off mute there. I wanted, all of these points I feel like are so critical. I want to lift up also one of Robin's first points. So she talked about, I would categorize them as effectiveness research and implementation research. And I think she pointed out that we do have a fair amount of effectiveness research. I think, and that we really need to push on the implementation research lever. I think we need to push on both, and I'll explain why. I think Robin, this is not to disagree with you. I think you were saying both, but you really talked about implementation research. But I think what we've seen in the care coordination literature is the kitchen sink. So the kitchen sink works. And I don't know that the kitchen sink is feasible for the healthcare system to sustain and apply universally. And I think we've heard that in other people's comments. And so if, we think that social, medical, and behavioral interventions are all really important, but we need to know which are the interventions that are most effective for which populations, and then how do you put effective interventions into practice. And then I just want to thread the needle there to Bill's comments about measure development. We have now had a chance to talk with, I think, almost 15 state Medicaid agencies, and I know NRC has done some great work with state Medicaid agencies trying to understand how they are approaching measure development around care coordination. And for our work specifically, it's been around measures related to social determinants. And I just want to underscore that what we're hearing from state Medicaid agencies is this very phased approach around, I'm going to put it in terms of the Donna-Bedian model, which I know not everybody thinks is perfect, but that we need measures that are going to walk people through how to do this. And that means structural measures of just like, do you have the capacity to do this? Do you have a workforce that can do provide social care? Do you have a technology system that can connect medical and social care providers and have closed loop referrals? And then there are the process measures of then we're going to hold people accountable for how much do they use those systems, how many patients, for which patients, and we need to figure out which is the right target population. And then we move on to the impact and outcomes. So I think that just is an important layer when we start to talk about quality measures in this field.
Thanks, Laura. Robin, you had a final comment on this section?
I did. No, thank you. I would never say we don't need more comparative effectiveness. So I want to tell Laura, oh no, I wasn't talking about implementation. Instead of, absolutely. And that's exactly why the standards for comparative effectiveness of these complex interventions were developed, because people have so much trouble writing proposals, for example, and including the aspects of this complex intervention, and care coordination is one of them. So we need much more. Boy, we are not done with developing models, and just saying that we do have somewhere effectiveness and efficiency are established and should be spread, and we don't tend to think about the implementation. So thank you for that. Also want to make the case about the supervision. So there are over 4 million nurses. And in the academic setting, for the undergraduate nurse, care coordination is something they leave our school with. So it's something that nurses can assess people, particularly with these complex diseases, that can actually make an assessment and make a good judgment about how to connect them back to their care team, their physician, et cetera. So the advanced practice nurses have been able to provide care. They're qualified clinicians, but the baccalaureate nurses are not. So I just would say that the baccalaureate nurse is I think, jewel for care coordination activities. They are ready, they know their communities, and they can work very autonomously, I think, and would even say in some circles could have their own care coordination model. So I would say think broadly, as we all do, but the more complex patient, I would say, needs someone like a nurse that can do an assessment, look at them, look at their functional status, look at where they're living, the social determinant, all the things we talked about. But I just want to mention that when we talk about supervision.
I was going to add a brief comment that, when we talk about metrics, the CAP survey is now about 30 years old and it's probably outlived its time. We used to get 35% the response rate. We're now in the 20s. It's becoming a ritual more than a valuable survey tool. And frankly, it probably doesn't bring up issues of care coordination, social determinants of care. So for those of you out there, maybe Robin, your group, it's time for a new CAPS survey, because frankly, it's probably a little out of date and needs some refreshing.
So the sand is running out of the hourglass here. And I said this to the panelists early when we first met before today's session, that there's no, despite our best efforts, it's still very challenging to get through all of the questions. So I apologize if there are thoughts and comments that folks want to make that we're not going to get to. But I think it's important as we sort of wrap up the session, I'd like to give a couple, like if there's any sort of barriers or things that we should focus on in our comments and our discussion around enablement of care coordination. We talked about payment, we talked about access to resources, technology, particularly even as basic as internet access. But if there's just, maybe I've got Bill, Sandra, and Laura have sort of been teed up in Sachin for this, but I don't think we're going to have time to get through all of that, but everyone. But if there's something very specific that we haven't talked about already as it relates to barriers or things that could really enhance the ability to coordinate care, it'd be great if we could go there. And I think Sandra's raised her hand. Maybe I'll call on you first, Sandra, and then others.
Thanks, Jeff, and I'll be very brief. I just wanted to recognize that, as we get into this discussion about complexity, the locus of care coordination may shift depending upon a lifespan, where someone is in the lifespan and where they touch the system, but also levels of acuity. And just remind us that there are others that are doing care coordination as well as you get into, more complex spaces like people who are in a housing first model. There are care coordinators all over the place. So as we think practically about the implementation science and models, recognizing that there are multiple care coordinators for people is really important, and will also help us figure out how to integrate better with the systems if we understand where that's happening.
Thank you. And I'm going to take a little bit of our break time, so we're going to go a little longer than the bottom of the hour, so we have a little bit more time. So any other panelists want to talk about their perspectives on challenges and things we should focus on to enable care coordination at this point?
The whole interoperability conundrum is a big issue. Smart Fire may be the answer, but if we can get extraction from electronic medical records into useful data flows, that'll be a major revolutionary step forward. It's a barrier, and it's been a barrier for several years. Maybe we're getting closer, but I put that at the top of the list.
All right. Anyone else? Any committee members that have questions for the panel? We have a little bit of time left. Again, I have one, but I'd like to hear from my committee members first.
Jeff, this is Paul. I just had a question about payment mechanisms, which some have alluded to, and Catherine, you particularly were alluding to use of TCM and CCM and things. I think we are in the reality is we are in a fee-for-service world currently, as we're moving towards, other models, but just comments on how the current payment schedule, fee schedule can be used effectively as you're implementing these care coordination models.
I am deeply concerned about CMS's over-reliance on risk for primary care, particularly primary care first. Again, I think the biggest issue is transformation of care and patient focus. And frankly, putting small practices at financial risk when they can't control a biologic variation in small populations is a mistake and potentially counterproductive. The goal should be better healthcare delivery. And you may not get there by putting people at financial risk. You reward better activities, better approaches to how you deliver care, but that may not necessarily mean you have to put them at financial risk.
Thanks, Bill. Catherine, you had a comment?
Maybe just a slight counterpoint there, Bill, to your comments, because I think what we've seen is that when the practices are able to take on financial risk in a partnership where they don't have the potential to totally lose their shirt, right? They have a partner that can help them get through that scary part of taking risk. We actually do see that we could get them to a point where they're able to implement and focus on the outcomes, right? So for me, I think that this one is critical for us to consider in terms of not just asking folks to implement a specific program, and where we need to go is help them understand the for whom and for how long. And I would underscore your comments about access to admission, discharge, and transfer data as a key to unlock one of those doors, because unless they know who is out there that needs support, that is urgent, they're going to sort of pour a broad intervention as thinly as they can across their population to drive up that particular fee-for-service element. So when I think about CCM and RPM, I'm thinking, wow, the reimbursement is so low per event that the incentive is to do it for as many patients as possible. Whereas what we should be aiming toward is a higher reimbursement structure that gets you to addressing the most critical patients who need that with the right level of licensure, right? Not a medical assistant, but with an RN that can actually help them. So that would be my point of thinking about the fee-for-service element as adding on, but within the risk-based pool.
Yeah. So we're going to lose several panelists at the bottom of the hour. So I think I'd like to thank each of you for taking your time to share your expertise and experience with us today. I'd like to, again, if we were in the Great Hall, we would ask the audience to join us in giving you guys a round of applause. But I just, on behalf of the committee and the audience, I can't thank you guys enough for all of your help and participation. This has been really, really a great discussion. And again, I wish we had more time, but we don't. So again, thank you all. We're going to take a short break and we're going to reconvene in about a half hour at 10 a.m. Pacific time, 1 p.m. Eastern time for a second panel. If you're joining on WebEx, you can stay, but note that we're going to a practice mode, so don't worry, we'll be back in time for the next panel. And guests whose organizations have submitted proposals to PTAC in the prior years, they'll be on, and we hope to see you all then. So we're going to take a quick break. Thank you, guys.
Produced by the U.S. Department of Health and Human Services.